Welcome to this concise video log on caring for an older man recently diagnosed with HIV-HBV coinfection. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and ViiV Healthcare. This vlog was recorded by Professor Jürgen Rockstroh. Please note his disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Professor Rockstroh from the Department of Medicine here at the University Hospital in Bonn, Germany. And I just saw an aging patient with newly diagnosed HIV and hepatitis B co-infection, who really represents a challenging case, which I see quite often in my practice. So watch this video to hear my thoughts on caring for this patient. So first, let me introduce you to some of the patient characteristics. This is a 63-year-old African male diagnosed with HIV and hepatitis B co-infection 9 months ago. Obviously, there's a higher endemicity for hepatitis B in Africa, so not so rarely that we see patients from Africa with chronic hepatitis B. He's been pretty stable on raltegravir FTC TDF since his diagnosis, but he does have some relevant comorbidities, including diabetes, arterial hypertension, and he's beginning to develop renal insufficiency, most likely as a result of the diabetes and the arterial hypertension. You can see here on the right that his CD4 count is already reconstituted, 377. His viral load is undetectable. He has no liver enzyme elevation, but he still shows signs of ongoing hepatitis B replication with an HBV DNA of 320 copies. His blood sugar is relatively well controlled, although you can see that he still has a somewhat elevated HbA1c. His creatinine is slightly elevated, and his GFR is declining, is now 58. Upon fibrosis evaluation, FibroScan, so non-invasive assessment of fibrosis score, shows us that he already has F2 fibrosis. His co-medications is metformin for treatment of the diabetes, and for arterial hypertension, he takes irbesartan. If we look at the global status of hepatitis B, it's clear this is a very common found infectious disease. 257 million people living with chronic hepatitis B, and as already pointed out, there is quite a large number in the African region, but also in the Western Pacific regions, so particularly check your Asian HIV patients for chronic hepatitis B. And 7.4% of persons who have HIV also have chronic hepatitis B infection. So that actually mounts up to quite a considerable amount of people living with hepatitis B co-infection on top of HIV. The proportion of children younger than 5 with chronic hepatitis B is really decreased, telling us that really vaccination has been successful. So I think that's one of the good things in the whole hepatitis field, is that actually worldwide global rollout of hepatitis B vaccination has been successful in preventing perinatal transmission in particular, and we're seeing less and less new infections in that particular age group. All right, so there's some important messages around management of hepatitis B and HIV. And the first one clearly is that co-infected individuals should receive antiviral therapy that includes TDF or TAF, unless there's a history of tenofovir intolerance. Obviously, tenofovir is great for patients with hepatitis B, as it works very well against hepatitis B, but also is a great drug for treating HIV. Now, the optimal treatment duration for nucleosides with anti-HBV activity has not yet been determined, and experts recommend lifelong therapy, maybe even more true in HIV patients, because HIV has to be treated lifelong anyway. In those where there is a need for changing the nucleoside backbone therapy, anti-HBV therapy can be stopped cautiously in HB antigen positive people without cirrhosis who have achieved HB seroconversion for at least 1 year, or after confirmed HBs seroconversion, and those are HB antigen negative. In patients with liver cirrhosis, stopping of effective anti-HBV treatment is really not recommended in order to avoid liver decompensation due to flares of liver enzymes. Now, in a patient who has co-infection, you should determine HBV DNA every 3 to 6 months, and at later time points, once the patient is suppressed, every 12 months. And you should also check routinely whether there is a change in HBs antigen status, whether there is seroconversion, and that probably could also be done every 12 months. Now, when you are talking of HBV therapy in someone who is an elderly patient, you may have to consider specific things, particularly since the patients may also have bone or renal disease, and obviously that's where toxicity of TDF may play in. So indications for using entecavir or TAF over tenofovir in the TDF formulation are really in patients who are above 60, in the presence of bone disease, in patients who have chronic steroid therapy or other medications that affect bone health, history of fragility, fractures, osteoporosis, and then obviously in the setting of renal abnormalities if the EGFR is below 60 and there are other signs of tubular damage. Now, when to prioritize TAF over entecavir according to the ASLD guidance is really in patients who had previous nucleoside exposure with lamivudine with or without adefovir resistance. So there have been good case studies also in HIV infected patients. If they have a prior treatment failure under 3TC in the setting of hepatitis B, then entecavir, even the double dose, does not really work very well, whereas you have good treatment success if you use tenofovir. So what does that all mean for our patient? I think here it's clear the patient has started to decline with his GFR, which is now below 60. So really this is the moment where TDF is contraindicated. And remember, he was still on TDF when I presented him to you. So this would be the moment where you would want to switch the patient to TAF, as obviously this would be much more beneficial for someone who has the tendency to develop more progressive renal disease over time, particularly in the presence of diabetes and arterial hypertension, which both can cause target organ damage involving the kidney. Now, one of the particular hallmarks of hepatitis B and HIV is that usually these patients have a much higher baseline HBV viral load. And as you can imagine, the higher your HBV viral load is, the least likely you will be to achieve fast suppression of hepatitis B replication. And there was a retrospective cohort study from the US which looked at 133 individuals with HIV and HBV coinfection and HBV viremia, and how did that develop after initiation of tenofovir-based ART. And you can see that only around half of the patient had complete suppression of HBV DNA at 1 year. So there is another half, which is obviously still replicating, just like the patient I showed you. And indeed, this incomplete suppression in this study was associated with higher HBV DNA level and detectable HIV viremia at 1 year. And I think that really points to the fact that when you treat someone for even extended periods of time, you have to be patient. It can take quite some time, particularly if they start with very high viral loads, until they all become undetectable. Now, obviously, you also want to make sure that the patient is compliant, but in the setting of HIV co-infection, if the patient is controlled for HIV replication, you can be pretty sure that he's taking the drug, because obviously the anti-HIV activity is easily to be observed with persistent undetectable HIV RNA. Now, one of the interesting features of treating hepatitis B in an HIV-infected individual is that you would at least expect that because the patient, if he has HIV when he gets hepatitis B co-infected, may be less likely to clear hepatitis B because of immune deficiency, which is HIV associated, which prevents sort of spontaneous clearance or control of HBV, as you would see in the majority of people. So if you have immune competent people and they undergo acute hepatitis B, only 5% end up with chronic infection. Now the question is, how does that all change, or what role does that have on seroconversion rates in patients with HIV and hepatitis B once they start HIV therapy and achieve immune reconstitution? So in a non-interventional retrospective cohort from 7 HIV centers in Germany, we looked at a large group of patients with HIV and HBV co-infection, almost 360 individuals, who received HBV-active ART with TAF or TDF, so according to the EX guidelines. And you then were able to assess the HBs antigen loss over time. And most surprisingly, 18.4% were able to show a loss of HBs antigen over time. Now note that this happened pretty late. So the median time to HBs antigen loss was 41 months. So you really have to follow up, which also means that when you monitor the patient, you have to repeatedly perform HBs antigen tests, because otherwise you're going to miss the seroconversion. And the parameters which were negatively associated with HBs antigen loss was having advanced HIV disease, defined as a CDC category C, a lower CD4 cell gain, and not receiving TDF-FTC. So, and I think that's important because that means that patients with HIV and hepatitis B are more likely to achieve seroconversion under tenofovir-based regimens than mono-infected patients, where usually in these trials under nucleoside therapy only, you have probably only a seroconversion rate of 1%. So that's really strikingly high and quite reassuring, because that obviously goes in hand with good control of the underlying hepatitis B co-infection. Now, of note, what we know from mono-infection, and that's why it's so important to treat hepatitis B, is that we do see fibrosis improvement over time with nucleoside therapy. And you see here the improvement of fibrosis score after 5 years of treatment with tenofovir, and you can see how dramatic the histologic improvement rates are. So clearly telling us that this therapy is associated with a good impact on fibrosis improvement over time, and obviously that has an impact on liver-associated morbidity and mortality. So really a treatment that makes lots of sense to prevent liver disease-related outcome events. Now, one of the important things to remember is that if you have chronic hepatitis B, you are at increased risk of developing hepatocellular carcinoma. And as such, the guidelines do recommend regular screening for HCC. This is a particularly strong recommendation, obviously, in all patients who are cirrhotic, because that risk is even higher, and that's true for chronic hepatitis B as well as for hepatitis C. But remember that in HBV positive non-cirrhotics, there are also specific groups in which HCC screening is recommended. So it's a little bit different than hepatitis C, where you predominantly screen the cirrhotic ones. Here, there are other risk factors, and you can develop HCC independent from the presence of cirrhosis. And that includes family history of HCC, ethnicity, so Asian Africans, hepatitis delta infection, and older patients. So thinking of the patient I presented to you, who's above 60 and of African heritage, I think it's clear that this patient should receive regular screening for HCC, which would be done with ultrasound, with or without AFP determination every 6 months. And I think that's important, so that if HCC should develop, we can intervene early enough so that we can lead to cure of that cancer form. Now, stopping anti-HB active ART should be avoided in patients with co-infection because of the high risk of severe hepatitis flares and decompensation following HBV reactivation hepatitis, unless there is a documented seroconversion. And I think one of the important things we have to remember is that, particularly when we see all the new HIV drug regimens hitting our armamentarium, that if you want to simplify the patient to a 2DR regimen or to injectables, remember that if there is still the presence of HBs antigen, you really have to keep an anti-HBV active NRTI, in this case TAF, on board to maintain HBV suppression, because otherwise you're going to see flare of hepatitis, which can cause very severe liver disease in that given individual. So HIV, HBV co-infected patients sometimes can be difficult to manage, but we have good treatment options. So thanks for joining me and discussing this patient with me.